The Midlands Decision Support Network, in association with the Strategy Unit, are holding this Insight Festival, a series of learning and sharing events for the NHS, local government and other partners across health and care. The festival runs through till a week on Friday, the 15th, and the theme this year is Insight to Action. And we've got a great set of, well, certainly from my point of view, inspirational speakers to explore how insights from high quality analysis can drive change in health and care systems. Before I introduce John as today's speaker, could you just note a few points of housekeeping? I'm sure we're all very used to these now, having practiced for a year and a half, but please keep your microphone muted during the session. Please introduce yourselves in the chat box. We're finding people from all over the country and indeed all over the world are joining these sessions, and it's extremely interesting for us to know who you are because it tells us a lot. So if you could take the trouble to introduce yourself in the chat, we'd appreciate it. Use the chat to raise any questions you'd like to ask John, and also if you've got any technical issues, and the team will pick those up. We are recording the sessions, and all of them will be on the Midlands Decision Support Network website as a permanent resource. Please tweet about the session if you do that kind of thing, and tweet about the Midlands Decision Support Network and the Strategy Unit. Right. I'm delighted. I'm really delighted. People always say I'm delighted. In this case, I am really delighted to introduce you to Professor John Wright. John is a doctor and an epidemiologist with a background in hospital medicine and public health in the UK and in Africa. John worked in parts of Africa on the front line through the HIV/AIDS tsunami and during the Ebola epidemic. John's established and leads the Bradford Institute for Health Research and the Wolfson Centre for Applied Health Research, working to speed up the translation of medical research into practice and policy. John's also Director of Research for the City of Bradford, and he leads the truly inspirational and world-leading Born in Bradford longitudinal study, which is combining clinical and social data and working with the now many thousands of citizen researchers who've been recruited to the programme. And we've posted some details about Born in Bradford in the chat for those of you who haven't seen it. And there's one particular thing we've posted, which I think is a fantastic example of taking research findings right the way through to tips for daily living for the citizen participants in the research programme. It's absolutely superb. Take the time to read it. I also want to thank John personally, actually, for the frontline diaries he kept during the pandemic for the BBC. Again, we've posted those in the chat. For me, they were a touchstone, actually. An essential slice of humanity and sanity, I thought, amidst all the uncertainties and the noise in the first wave and lockdown. Really powerful stories, beautifully written, I thought, beautifully written. And I'd recommend them to everyone. Really, that you should take the time if you can to read them. They're a fantastic human history of what we went through in the pandemic. Anyway, today, John's talking to us about what we can learn from the pandemic to reduce health inequalities. So John, over to you. Thank you very much.
Peter, that was a very kind introduction. Can you hear me? Can somebody just nod to make sure that my microphone's working? Good. Okay, so, well, thank you very much for inviting me. I'm a big fan of the strategy unit. I think it's a great model, and if I could do something in Yorkshire, I would clone you all and bring you up here. So we'll have to have a conversation about that later, Peter. I'm going to talk a bit about a few things, actually. For an Insights conference, I thought I'd provide a little bit of insight about global health, about place, about systems, but also, as Peter alluded to in that introduction, I'm going to try and weave it together in a bit of a story, and that story is my own personal insights into this. So I'm starting with this slide from some of my colleagues on the wards at Bradford Royal Infirmary. I'm full of admiration for all of them, and the patients who've had to suffer from COVID, and what a nasty illness this has been. I think one of the things on the front line is how quickly you picked up how unequal this disease was, both in terms of the types of patients that we were seeing, in terms of age initially, but in terms of ethnicity and socioeconomic status as the pandemic went on. And we still see that today, with most of our patients are unvaccinated, and that's got deeply rooted in inequalities. I'm going to talk firstly about my slide changes. About global health, though. I love this infographic. It's such a wonderful transposition of the irony of champagne glasses versus the distribution of wealth. It really highlights that while we focus a lot about inequalities in health in the UK, actually the real inequalities are global inequalities. And when you look at these distributions, 82% of the population having being the richest 20%, actually those distributions probably aren't far off our current vaccination rates across the world. So in our low-income countries, it's probably less than 2% in terms of vaccination coverage. And that's something that is deeply concerning, particularly as we move to booster vaccines in this country when the benefit is pretty unproven and we don't know how long our immunity lasts, and we're taking much needed vaccines from the rest of the world. So we should be contemplative about that. The other bit about this is it's not just about countries, it's also about individuals. And this Oxfam graphic about 8 people having the same amount of wealth as half the population is just abhorrent. And we have the Pandora Papers in the news over the last couple of days. One of the best things we can do about addressing inequalities is about fairer taxation. But it's also about addressing tax loopholes and tax havens. They are so crucial in our efforts to get a fairer society. So let me start with a little bit of a personal history. So I did hospital medical training after qualifying, and then worked with my wife for 3 years in a small rural African hospital on the Mozambican border in Swaziland, now Eswatini. And it was a profound period in the early 90s of political change. There was the end of a very malevolent political system of apartheid, just 100 miles south of the hospital. And then just a few miles east was a raging civil war between Frelimo and Renamo in Mozambique, a beautiful country, but devastated by the remains of the Cold War. And the hospital was also a great professional development for me. Both clinically, we were 3 doctors working in this hospital, covering about 250,000 people. There were about 100,000 Mozambican refugees in addition to that. And we ended up doing everything, so surgery and obstetrics, and here pediatrics. I grimace when I see this photograph. One of the things when I was doing this talk, I wanted to find a photograph. This is the only photograph of me in the hospital because we didn't have mobile phones, so we never took any photographs. So this is a rare image, but also slightly embarrassing because my wife's parents were teachers, and they did some fundraising for the children's ward. The children's ward is that dark cave on the right of the picture, and the children would play around on the veranda until HIV came and we had to turn it into another ward, and then go back and sleep 3 to a cot in the pediatric ward. But they had nothing to do, so my in-laws very kindly did a fundraising event at their school and brought all these soft toys into the cesspit of infectious disease that was that children's ward. And I grimace when I see them with these soft toys, thinking about the infection control issues that we probably created. It was also a big personal change. I tweeted this photograph last week, and its significance is that my daughter Catherine in that picture is now 30. She was 30 Friday. And it was, well, I was the midwife because there were only two of us in the hospital at the time. I'm not sure who was the most terrifying, me in terms of the idea of the decision making, or my wife with the idea as me as her midwife. But it all went well. And Catherine now works for Acorn, which is a community organization, a great organization. So if you come across it, please do. It's the sort of thing that we should be supporting if we're really serious about addressing inequalities. It's about that grassroots community development, which is so important. But I also use it to illustrate the fact that I grew up in the 60s and 70s when actually inequalities in this country were falling. In those post-war years, 50s and 60s and 70s, where we were moving towards a fairer society. And Catherine has grown up over the last 30 years when inequalities have been rising inexorably. And I think that's that difference in generation is really quite fundamental. The other thing about my time there was this virus, another spiked virus. It's not the SARS coronavirus. It's a HIV virus, and it was a virus that took over the world, but in particular took over Southern Africa. And over our time there, we could see the early implications of it, the sort of rapid rise of opportunistic infections and TB. And also the approaches, the naive colonial approaches for how we addressed it. So the one thing that I really hated at the time, the US aid, the US is very tight-fisted when it comes to international aid. It's something that's less than 0.2% of GDP. It's embarrassing, really, but they're very good at branding everything they do. So everything that, whether it was giving out a computer or, setting up a new gatepost, they would have the stars and stripes emblazoned on everything. And they had these signs outside the hospital. This isn't one of them, but it was a big stars and stripes with a similar message: say no to sex. And not surprisingly, when we asked the young people what they thought about this, they said, well, it's we have our own acronym for AIDS. It's the American invention to discourage sex. And some of that issue about how we build that trust in communities is a thread that runs through both my work in Sierra Leone, but also more recently in Bradford with COVID. This is a graph from Gapminder, wonderful website. Hans Rosling was a fantastic innovator, and for the strategy unit being so interested in analytics, I'm sure they'll appreciate the website. But this is life expectancy over the last 150 years or so, and you can see those dips in the US and the UK, the American Civil War in the 1860s, the First World War and the Spanish flu in the just before the 1920s. And Swaziland, Eswatini, similar dips in the 1819 years, but that incredible loss of life expectancy in the early 90s onwards, from sort of early 60s down to early 40s, a 20-year, third of life expectancy was lost. It was quite remarkable. And the place that I worked, Lubombo, this region, became one of the epicenters of HIV. 40% of adults were HIV positive. And one of the remarkable things of that slope going the other way, at the time, antiretroviral treatment was new, it was very expensive, 10,000, 20,000 pounds a year per course of treatment. And the idea that we could bring it to Africa just seemed something that we couldn't possibly do. But within a few years, with the weight of the world's political pressure, we brought antiretroviral treatments within a few years of me being there to everybody. This life-saving treatment, this remarkable treatment that stopped that drop in life expectancy, and we did it because we dropped patency and intellectual property, and we worked with countries to provide low-cost manufacturing. And there are also lessons here for the COVID vaccinations about doing similar things. We have Moderna and Pfizer on track to earn, you know, hundreds of billions of dollars of profit. This is war profiteering. And the idea that they can't share intellectual property or drop patencies is, I think, is one of the big debates of our time. My other reflection for this very formative period in my life was the importance of place. And I think this is something that we all have wherever we work, whether it's Birmingham or Wolverhampton or Nottingham or Bradford, is that most of us work in one place for the majority of our time, you know, particularly in the NHS and doctors and nurses, academics, but we tend to, you know, be in one place for 30 or 40 years. And those roots that we put down in these places are powerful roots. We tend to have an understanding about our communities. Unlike our leaders who tend to come and go, whether they're political or organizational, you know, we have those close connections. And I remember standing in the high street in Staigy, in the middle of, you know, when it was the sort of epicenter of HIV and poverty at the time, and listening to the laughter and the joy in people's voices and thinking, actually, you know, there's something much more important than about that connectivity and that community, and that is so key to tapping into. I returned, did a bit of public health training, and then ended up in a very different place in Bradford. And it's an important city. I think it's the 5th biggest city in the UK, but benignly neglected. It's a poor city, very diverse city. When we look at Born in Bradford, for example, 50% of our under 18-year-olds are of South Asian heritage now. So it's a city of social change. But a very vibrant and international city as well. So I'm very proud to be part of this city, and it's very much part of my personal and professional journey as well. But I have kept my international links, and I spend my summers, or until recently, going to Eswatini and working as a doctor there as a busman's holiday, and doing stuff in Pakistan as well, but also when Ebola came, going over to Bradford's twin city, well, twin village actually, in the middle of Sierra Leone, to work with Medicos del Mundo and setting up an Ebola treatment center. And that was fascinating. It was a, you know, very different virus from COVID, much higher mortality, much in this hemorrhagic disease that it caused. But lots of similar lessons about how we could deal with it. One of the features of setting up an Ebola treatment center is that I had to work with the British Army so I was based with this group of squaddies, sort of 30 or 40 squaddies, in a mosquito-infested, dank basement in an abandoned sports stadium. I grew up with Irish parents, Irish Republican parents. So the sort of British Army never had a most positive reputation, but I was deeply impressed by these guys, and I have very fond memories of them. We had a different Conservative Prime Minister at the time, David Cameron, but as you can see, there was still a fuel problem, and I was giving this Royal Navy seeking helicopter a bit of a lift to get it off the ground. One of the things about working with the military also is that it does have unintended consequences, and that is a little bit about how you frame healthcare. And we saw a little bit of that on the streets of Birmingham and the streets of Bradford when the army was brought in, so we have to be careful about that. But the Royal Engineers built this amazing Ebola treatment centre in the middle of what was jungle in the space of about 6 weeks, and that sort of was my first experience of isolation hospitals, red zones and green zones and white zones. I never thought that I'd have to set up something in my own hospital. We still have red zones and green zones. I'm not sure of our exit strategy from moving out of red zones at the moment. But it's something that became increasingly important about PPE and infection control as COVID came in. And the big difference between Ebola and COVID was that we managed to keep it in Africa. And this cartoon, I think, highlights some of the attention at the time that was spread to it. It was a threat of spread that really alarmed us. And the slide at the bottom, that's from Sierra Leone, has great expertise in Lassa fever, which is another viral hemorrhagic disease. And we used to spray our feet entering and leaving the treatment centres. And one of my colleagues from MSF said the reason why we're so interested in Ebola is that we don't carry poverty on the soles of our feet. And that's almost similar to COVID. We don't, COVID is carried on our breath, unfortunately, not just on the soles of our feet. So when the epidemic was hurtling our way from China and southern Europe towards the shores of the UK, it was very clear a city like Bradford, like some of the cities in the Midlands, was going to be at high risk. You know, lots of overcrowding in housing, multi-generational houses, as in Spain and Italy, and lots of comorbidity, high levels of comorbidity to increase the risk of severe disease. So there was a frustration that I think probably many of you shared in the late weeks of February, early weeks of March, of the lack of how this was being taken seriously. And a week before the lockdown was announced on the 23rd, we got out on the streets of Bradford just to tell people to stay at home, using our community networks, our sort of deep, strong community networks to really get the message across. Take your children out of school, stay at home. And those were probably, those were powerful messages that I think protected us in the early days. This photograph looks like a really bad 1980s pop group, but it is some of the community workers and myself out on the streets of Bradford at the time. We, those first few weeks were taken up with the sort of clinical acute side, doing all the sort of dress rehearsals, preparing additional ICU beds, getting ventilators, all that sort of stuff. But also as the first few weeks went by and lockdown took hold, a recognition that we were losing track of our communities. One of the things about working in Sierra Leone was that sort of loss of trust. When you're working in isolation facilities, people don't know what's going on, and the loss of that sort of prohibition of visitors into hospital led to similar rumors that we had here at the time. So back in Sierra Leone and Moyamba, it was we were injecting people with Ebola in the treatment centers because nobody had access to it, and we saw similar sort of things happening in hospitals across the UK. People scared to come in from at A&E because they thought we were going to kill them, that we were going to COVID wasn't a proper, all the fake news stuff that you'll be familiar with. So one of the things that we had to our advantage in Bradford, as Peter mentioned, was born in Bradford. So we have about 50,000 Bradfordians involved in our different cohort studies now, and this provided a really strong link to track what was going on at the time. But it's also provided, unusually, we're not Oxford in Bradford, far better, obviously. But we do have, unusually, a real centre of epidemiological expertise, analytical expertise that's built up as part of this cohort. And so when, in those early days of lockdown, we pivoted all our expertise that we had, our community, our qualitative research, our epidemiological research, to set up our own independent, not our independent SAGE, but our COVID Scientific Advisory Group, our own Bradford SAGE. And that became embedded into our hospital goal command, but also our district goal command. And I think that sort of link of evidence and science, which was so embedded into policy making over the last 18 months, has a legacy now of how we can become more evidence-based in our decision-making post-pandemic in terms of the recovery. And our CSAG group, we were able to do our own local modelling. Some of the early work on CPAP came from my colleague Tom Lawton, very cutting-edge, trailblazing work on CPAP and the benefits of CPAP, and he did publish some of that work about impact on mortality. But perhaps most powerfully is the links into tracking what was happening into our communities, into our people. And for that, we used our links into Born in Bradford. And over the course of the last 18 months, we've been able to track people's financial, economic insecurity, their mental health, their physical health. And you can see from this slide how those impacts were unequally distributed. So those impacts about job insecurity, food insecurity were much higher, inevitably, in those who were unemployed, those who were self-employed, not working, and those who were self-employed, employed on furlough. The furlough, people think about, 80% of your salary. Well, that's pretty good. But actually, if your salary is so towards the breadline that loss of 20% can mean the difference between food on your table or not. And we'd also done, just before the beginning of lockdown, this survey of primary school children, 8, 9, 10, about 16,000 of them. And it provided this real insight into what lives were like. So I think for a lot of people, reflecting back on those months of April and May, sunshine, gardens, walking around neighborhoods and parks, I think it's salutary to think that for a lot of our populations, it wasn't like that. So 13% had no garden, 30% had no nearby park, 26% were worrying all the time. So this sort of background probability of mental health. 50% being bullied all the time. Again, that sort of underlying vulnerability. 30% of children keeping the worries to themselves. So you have this sort of background level of, also, sorry, 20% had no laptop or internet at home. And, that sort of, we had stories of children trying to do their homework on their mother's mobile phone, but running out of data. So while for many people, it was a time of family bonding and exercise, for our poorest section of society, it definitely wasn't. And we could track that through mental health scores, our PHQ GAD-7 scores. If you were comfortably off, actually you had improvements in your mental health. It was a time of benefit. But for those who were struggling to get by, difficulty getting by, there were these sharp increases in anxiety and depression. And we were also able to do some of this sort of early work, very cutting edge, early work on vaccine hesitancy, about the fake news, showing the sort of social patterns of uptake, not just by ethnicity, but also by socioeconomic group, and feeding that into our district and hospital goal commands, into how we address increasing vaccine uptake through addressing fake news, role modeling, countering all that sort of stuff. And poster campaigns, and trying to pick up how we could address that. So whether we made an impact or not, who knows? We were one of the hardest hit in the top 10% of local authorities in terms of infection rates, but actually our mortality rates were lower than we expected. So it may be that our collaborative effort, anyway, we're going to take credit for it between us. So never mind the evidence. I also, as Peter mentioned at the start, I did some podcasts. When I was in Sierra Leone, we have a Born in Bradford radio program that goes out once or twice a year with Winifred Robinson and Sue Mitchell. And they'd given me a recorder. So when I went out to Sierra Leone, I became a sort of a cub reporter for the BBC and did a number of programs, which I think are still on BBC Sounds, about Ebola Junction. And so when lockdown suddenly hit us, I had this old recorder, well, not that old, but it was sort of dust covered on the shelf. And they asked me to start doing recordings from my colleagues, which I did. And if you listen again on BBC Sounds, you can capture some of the remarkable voices, the remarkable stories. There's a real media clampdown by the NHSEI at the time. So the stories, the media was very closely monitored, but we managed to get away with actually telling it how it was, the shortages of PPE, the lack of testing, the fear of people coming on to working on the red zones for the first time, the voices of the patients and the communities. So very powerful stories. And I'm the amanuensis for these voices. But also quite crucially, the resilience and bravery of the staff and the common sense of our communities in terms of how they were dealing with this. So let's move on a little bit and talk a little bit about inequalities. I know it's party political season at the moment, so I thought I'd see what happens when you correlate those, not me doing this actually, by Labour vote by constituency about COVID, and you can see this correlation. It's not about, COVID isn't party political, but it does reflect that the poorer parts of our country were hardest hit, and they tend to be Labour voting. So let's go back to the that initial discussion about life expectancy. And this graph shows life expectancy by 25-year time periods from 1850 when the Brontes were up the road from where I'm sitting in the hospital at the moment. When you look at their family tree, you can see that half of them died in infancy and early life because of that communicable disease that was so prevalent in low-income countries where I was working in Africa before. So that rapid decline in the early years was very much something that was eliminated through good public health, through sanitation, hygiene, and vaccination and immunizations. And you can see that sort of improvement in life expectancy over the last 160 years. Until this year, when, last year we had the early inklings that life expectancy was stalling and even falling in certain groups, poorest groups. And this year it has dropped by about a year and a bit. And that life expectancy is not equally distributed. So you will all be aware about Michael Marmot's review and the tube journey from Westminster losing a year per stop. And we can, any city, I think, in this country can come up with similar sort of things, that sort of 10-year life expectancy difference. And even more so in terms of healthy life expectancy, which is perhaps a better marker, that 20-year difference between the poorest and the richest in our society. And the important thing about this slide is it's not just about the rich and the poor. Every step along, every dot along this graph, just being a little bit wealthier, you improve your healthy life expectancy and life expectancy. And going back to Catherine and her growing up in the 90s, me growing up in the 60s and 70s, relative poverty, that's income less than 60% of the national average, was pretty stable until the early 80s. I can't remember what happened in the early 80s politically, but you can see this rapid rise of relative poverty, particularly amongst working people and children. It stabilized a bit in the late 90s and early noughties. Things like Sure Start, I'm sure, helped that fall in children. But unfortunately, inevitably has been rising more recently. And, let's not kid ourselves. Money is perhaps the greatest medicine. And if we're serious about addressing inequality, we do need to think not just about tax havens, but about progressive taxation. And the national insurance contribution rise is a regressive taxation. So that taxation, this is a slightly old slide from the Institute of Fiscal Studies, but sort of highlights how unfair tax changes were happening over recent years, where the poorest suffering, and you see that again this week with the loss of the £20 universal credit, and the wealthiest, that's me included, me especially, almost gaining, which doesn't seem fair, actually. I think most people would say that. And that plays into our health indicators. So one of my observations is, I think that there's real marker conditions, and I think mental health's one of them. For the last 30 years, perhaps mental health's just getting worse and worse and worse. Nothing that we do seems to make very much difference, and our health service focus on that. So we're building more, getting more IAPs and more mental health units and more mental health staff is the wrong end of the spectrum to focus on. The same with childhood obesity. So we'll be building bigger coronary care units and diabetes centres all over the country to prepare for our rising rates, as 2/3 of the population, adult population, are overweight and obese. But its roots are happening in childhood, and that's something that's very much been the focus of my more recent personal journey. And here you see it's that rise in the national child measurements during primary school years from entry to exit, but how this is again socially patterned. And we've been studying this quite closely in Born in Bradford. It's with 50% of our children of South Asian heritage. One of the interesting things, and one of the features, there were a couple of reasons why we set it up originally, but we had the highest infant mortality rate in the country. We had the highest, the lowest healthy life expectancy in the country, some of the highest rates of childhood obesity. And what you notice in South Asian babies is that they have what's called a fat-thin phenotype. So they tend to be born smaller, tend to have more lower birth weight, but have higher levels of adiposity. And that's probably useful in times of famine and fasting and feast and famine, but less useful when there's McDonald's in every corner, as there are now in the UK, but also in Pakistan, which is seeing soaring rates of diabetes. So we've been tracking, and you can see this very clear trajectory from whether it's hormonal levels in the cord blood of the newborn babies, of fat markers like leptin and adiponectin, 30% higher in our South Asian babies, through to markers of adiposity as the children grow up. We've just been doing DEXA scans on the children, and the difference between there's a difference between a South Asian girl at the age of 9 and a white British girl at the age of 9, is something like 2 kilograms of fat, 2 kilograms of fat. And you can track through lifestyle changes. So there's genetic components, but also lifestyle differences. You can see very much the widening trajectories from almost from birth, definitely after the first year, in terms of unhealthy diet, in terms of physical activity. So this is really highlighting the importance of intervening earlier if we're going to make a difference, if we're going to protect the NHS from going under in another 20 or 30 years' time. And Born in Bradford shown lots of other things. Increasingly, it's moving towards more environmental, reflecting our focus on climate change. There's also environmental. So the benefits of green space on our mental health, the harms of air pollution. We've shown very definitive evidence about harms in intrauterine growth, on childhood asthma, and that has turned into very ambitious clean air zones. But also our diet. We've been picking up pesticides that were banned 30 years ago in the blood of our children, and that shows how poisonous our ecosystems are. These poisonous chemicals going into the ground, into the streams, into the rivers, into the fish, and back into us. And you can see these strong patterns, even at a molecular level. So you can show how we've shown how your telomeres, your sort of strands of DNA at the end of your chromosomes, which are markers of biological aging, so like a biological clock. And you can show that the nearer you live to a air polluted street, a road, the shorter your telomeres at the age of 4 or 5. So these are very, very wide and wide determinants of our future health. We're moving. We just got told by Wellcome that they're going to fund our next phase of Born in Bradford, so we're very delighted about that. Age of Wonder, it's called, the teenage years, and what a tumultuous period this is for this transition between childhood and adulthood, of social, physiological, biological change. So we're excited by this. We want to recruit not just every Born in Bradford child, but every teenager in Bradford to be part of this study, whether it's gene sequencing or measuring your vitamin D levels, and get the young people excited about science, really create a generation of citizen scientists. I think something like only 40% of children in Bradford get basic GCSEs in English and maths. And if we're going to change these young people's health outcomes, we've got to change their educational outcomes. So follow us if you're interested in teenage health, adolescent health. Then this is going to be it is going to be the biggest study of adolescents in the world, and a big focus on mental health is part of that, because we know that these young people are really bearing the brunt, the loss of their interactions at school, and all this sort of austerity and Brexit that's happening around them. So one of my observations over the last few years is that for all our wonderful science in Born in Bradford, the key thing that occurs over and over again is that everything depends on your income. Everything is socially patterned, and you get a little bit frustrated about just telling the same old story over and over again. So that's led us to think about our next stage of where we go, real system change. And I use this photograph of 3 boys sitting in a bit of a wasteland. It's a little bit old. Ian Beasley's done most of our photographs. Carolyn Mendelssohn did the photographs before. I should have shouted those out. Who are artists in residence. And these 3 young boys, I think, highlight how difficult it is. So, you know, dealing with COVID's complicated. Getting a vaccine is tricky, but actually it's quite simple. It's targeting a single agent. Dealing with non-communicable disease is far more complex. And the influences on these young men's health are going to be the housing that they live in, you know, often rented housing with very poor kitchens, so you can't cook. It's going to be damp. They're going to have very poor access to green space, poor quality green space. The roads are going to be full of cars, which are going to run them over, full of air pollution, which is going to damage their respiratory health and other aspects of their health. Schools are going to tend to be struggling. A high proportion of children with an English as a second language, so tend to struggle with educational attainment. And the neighborhood's going to be full of fast food takeaways, food swamps of takeaways, and food deserts of healthy food choices, and lots of crime. So you have these complex influences that are all going to affect, and how do you start dealing with it? This is some of our evidence from Born in Bradford about that social patterning in terms of green space, in terms of noise. We're increasingly interested in noise. One of my bugbears at the moment is ambulance sirens, because I don't think it makes any difference to the survival, but it creates this adrenaline rush in everybody that it passes by. So noise, and generally noise of traffic noise and everything, is bad for our health. It's not a good thing, and increasingly we're picking up the signals of that, and particulate matter from air pollution. And when we think about how we deal with these, we have to move away from the focus on behavior, which has inevitably benefited the wealthier. So, you know, I suspect many people listening in today, you know, very few people smoke. I bet lots of people have got Fitbits. I bet you all know what quinoa salads look like. And that focus on behavior is widening that inequality, because it doesn't tackle those structural determinants of health. And to do that, we need much more emphasis on fiscal and legislative changes. This is an example of soft sugar tax, which we've introduced here. Seems to have a good effect, though there's been displacement to the sugary drinks that aren't taxed. But here in Mexico, with braver legislation, they've shown this increase in bottled water, which is good. Even some of the behavioral fiscal legislative stuff, such as smoking and seatbelts, still focuses a little bit too much on behavior. And over the last 18 months, there's a second pandemic of non-communicable disease that we've been ignoring. And I do think it's a little bit like children playing football on a Saturday afternoon in the park. Everybody's been chasing the COVID ball, while the open net of non-communicable disease has been left unattended. And I think we really have to think about what the lessons are from what we've done so successfully over the last 18 months to how we can move on to tackle our high rates of mental ill health, diabetes, cardiovascular disease, stroke, cancer. And there are some powerful lessons in what we've done. You know, that sort of a brave government, eventually, government legislation, the emergency legislation that, you know, took this seriously and was empowered to make the changes needed to make the public health legislation necessary to tackle this infectious disease. But also the local system, our district goal commands, for example, being empowered and our clinical goal commands being empowered for rapid decision making to do what's right. So we need to keep hold of, you know, we can do this if we turn our mind to it, but it's too hard, it's too far off in the future, so nobody has that same urgency about it. We need to turn that urgency, even in terms of data, thinking the strategy unit, you know, we have, you know, what a fantastic use of data we've shown over the last 18 months with Open Safely and all the other approaches, you know, PHE and ONS and all the surveys. You know, if we had the same urgency around diabetes, so we track down every single case of diabetes and intervene and support, imagine what we could do, but we won't. We won't because it's too complex, and the influences are too complex. It's not a single agent. You'll have seen this foresight complex system. about obesity before. But it's it is a complex system, and it's self-organizing, it's dynamic, has unintended consequences, has amplification loops and dampening loops, and is fundamentally non-linear. And as scientists and clinicians and policymakers, we tend to be very linear. We want something like the Daily Mile to conquer, to cure obesity. When you're living in wider neighborhoods, how on earth is it going to make an impact? And we scatter these public health interventions, which are well-intentioned, but are unlikely to make an impact by themselves. And one of the aims of one of the components of a complex system is that it has a tipping point, and that's something that we're trying to see whether we can reach. So this tipping point where, if you have, what our ambition is, if you have enough cumulative interventions in one place, you might actually start making a difference. And that's what we're doing. We were funded by the UK Prevention Research Partnership 18 months ago, or 2 years ago even, God, time flies, to set up a city collaboratory in Bradford to look at how we can use epidemiology and science and evidence to focus on, away from the NHS, which has, maybe 10, 15, 20% impact, well, no, sorry, 10% impact on our health, to the wider determinants, which are much more important. And you'll be aware about the sort of disparity of research funding. 95% of our research funding tends to be more biomedical. We all want a cure for cancer, whereas probably 90% of our health is determined by these wider determinants. So we're looking at now working with the local governments in Bradford and Tower Hamlets as our replication site, to look to see how we can influence urban design and transport and arts and culture schools to try and reach that tipping point. I'm going to illustrate that with this is 7-year-old Samina, with the idea of a school super zone. So when Samina walks to school, or drives to school, should I say, she faces the pollution from inner city areas, lots of traffic, lack of green space. She's going to be sitting down at school all day. And then, 90% of our Muslim children go to madrasas after school. So they'll rush home, have a packet of crisps and a Coca-Cola, and then spend 2 hours sedentary in the madrasas, and then come home and have some chicken and chips, because you can get it for £1, which is cheaper than you can get healthy food. So you've got the fast food outlets and healthy school meals. And so, rather than tackling each of these exposures individually, can we do something more to be interlinked and tackle them all together? And if we can do that, we're not going to just change a single outcome like obesity. We're going to improve physical health, educational attainment potentially, and mental health. This morning's Guardian, Birmingham, well done Birmingham, a super-sized low-traffic neighbourhood. I'm going to move to Birmingham, actually. My sort of all the evidence from Born in Bradford about the harm of air pollution in cars. It's not just the air pollution, it's the noise. It's not just that they kill poor children by running them over. It's they lose our connectivity, and that connectivity in society is so fundamental. They break up our urban spaces. So well done, Birmingham. Fundamental to this is community engagement. Going back to that grassroots bit, is this has got to be bottom up. Looking at the assets in our community and how we harness those for change. Bringing in a supersized low traffic neighbourhood is going to need that community engagement, because otherwise the car drivers are going to start shouting and say what to do. It's going to need good data. Because the difference between myself and the witch doctor who worked down the road in Eswatini when I was working there, he was far more popular than I was, and had a far better surroundings, leopard skin on the floor type stuff. But the difference between us and everybody else is that we should be evidence-based. And I think in public health, I've seen over the last 25 years in the NHS, lots of well-meaning initiatives, but stuff that we don't know whether it works or not. And to do that, we need to be creative. We need better routing linked data, and we're trying to do that as you're doing, as the strategy unit are doing, across sectors, so not just between primary and secondary care, but across all our sectors. And thinking about how we become more creative in our evaluations. So the evidence that our policymakers need isn't necessarily a randomized control trial. They need timely evidence which is useful to them. And particularly for public health interventions, which aren't linear necessarily, are complex. I think we need to be more creative about using, before and after interrupted time series, trials within cohorts, things that can provide timely evidence in a more efficient way than a multi-million-pound randomized controlled trial. And one example of this is Bradford, just down the road from me in Green Lane Primary School, was the first school to introduce free school meals. And I found this photograph of this before and after free school meals in Bradford. And I just thought, great, look at them, not only doing great public health interventions, but also evaluating it. My only slight reservation is I couldn't tell which side had had the free school meals. But hey, it's a start. And for me, that's the end. So thank you very much. We've got a little bit of time for questions. So I'm going to stop sharing. And
thank you very much, John. As you say, we've got about 7 minutes. I haven't been able to, I've been tracking the chat. Have we had any questions coming through, Rachel and Janine, that you've spotted? I've got a few, but...
Oh, desperation, Peter, that you have to answer questions, but I admire you for it.
Well,
we've had, sorry, Peter, but there's one or two, but why don't you go ahead, and we'll go back to this instead.
Well, I suppose I wanted your, I'd be interested in your observations, John, because born in Bradford, it seems to me you're giving equal weight to information and understanding what people think about things and what they feel about things and their experiences as you are to hard clinical data. And you're trying to join those two things up to get insight. And I wondered if there are any examples you had where it was the bringing of those two things together that had led to breakthrough understanding.
Yeah, when we started Born in Bradford, which we started on a shoestring, but one of the things we did right at the last minute was we consented everybody for routine data linkage. That was 2006, so it wasn't obvious in people's minds that this was important, but we asked all the mums and dads to consent to data linkage. And actually, for all the fancy metabolomics and proteomics, actually just the routine data has been the biggest treasure trove. So I'll give you some examples where we looked at reception, looking at reception year early stage foundation profiles from the reception teachers, and we found it was highly predictive of autism at age 6, 7, 8. So we redesigned the CAM service to provide early interventions in reception year rather than wait and have these children with no diagnosis, no care later on. Another example is linking prematurity and education SATS outcomes. You can show that if you're a summer birthday premature, you have worse outcomes. So we've worked with the council to change the policy for school entry. So if you've got a premature baby born in the summer months, you can delay till September. So little things like that are really nice, I think. Clean air zones also, we've got a really ambitious clean air zone because of all the evidence from Born in Bradford. So they've been very, very supportive of that.
Yeah. And in your document from Born in Bradford, there was a fascinating, well, one of the many documents, there was a fascinating bit where you asked your young citizen researchers or citizen scientists, I forget which term you use, you said to them, if you had unlimited resources, what would you spend it on to improve life for young people? And well, maybe you can remember some of the answers that they came back with, but I was rather stunned by what they came back with actually as an insight into people's lives. Are you able to say a few things about that?
I can't remember, Peter. It's not Lamborghinis, is it?
Well, they said things like stop vaping.
Yeah.
They said things about noise, as you talked about. They were simple things. Yeah, simple things. It's in the magazine that we've put in the chat. So everyone can have the challenge of go and find that page in the magazine and see what those young people said, and kind of reflect on it. It was
yeah, we do some stuff on clean air around schools at the moment. You know, planting trees and getting citizen scientists from the 8, 9, 10-year-olds. And I went and talked to a group of them, and I said, there must have been about 10 of them. And I said, right, who's got asthma? And they all put their hands up. And we've shown this very strong link, 25% of asthma in Bradford is linked to air pollution. And so getting them as advocates for the car driving parents to say, maybe, don't give us more inhalers, stop driving around the school.
Yeah. Anyway, a huge amount of food for thought there, John. A wonderful presentation. Thank you very much, and thank you, John. Thank you again for giving us an hour of your time. It was a wonderful session. And goodbye, everybody.